This discussion will be a short reflection on when I observed craniotomy procedure. I've always enjoyed the thought of the operating room. I was already in conversation with the neuro-oncologist asking if there was any possibility I could observe a tumour dissection for my personal development and desire. So when a day in theatre was offered through clinical placement, I wasn't going to let it pass. I was told they could not say which tumour it would be that would be dissected, but they have booked me a day in a theatre. On the day, I was up early, had breakfast for a change, and was at the theatre 30 minutes before. I know, sounds keen. The ODP, an operating department practitioner, came, introduced herself, and could sense that I was feeling nervous. I knew she had noticed this, so like always, to hide my nerves, I talk. I started asking what she was doing and if she would please talk me through the process of preparing the theatre. And wow, she tells me it's a craniotomy. I was so excited. I had been waiting months for this, and now I actually get to observe a craniotomy. I get to see a brain dissected. I feel like there's something so unique about surgery. I feel that it is almost indescribable. There is a unique bond between a patient and the surgeon. The patient allows the surgeon to do something life-altering. The surgeon has the responsibility of someone's life in his or her hands. The complications are real, but the outcome and satisfaction is exponential. So one theatre has a total of 8 to 10 different healthcare professionals, all vitally important just as much as the surgeon carrying out the surgery and the registrar helping the surgeon open and close the area, and the anaesthetists. So first, they prepare the theatre and conduct the first meeting of all staff present in the theatre for surgery. There's a surgical checklist. This is globally applicable to most surgical procedures. It involves an item checklist and allows consistency of care, reducing complications and even death rates. It is used as a 3-junction, so before the induction of the anaesthesia, this is called the sign-in, before the incision of the skin, this is called time-out, and before the patient leaves the operating room, that's called sign-out. Each step is read out, allowing active communication amongst operating team and the rest of the theatre staff. Firstly, everyone present introduces themselves and says what role they have in this theatre, and if there's been any changes made to the plan. In this case, the surgeon said that the surgery is expected to last 8 hours due to the close proximity of the tumour and the optic chiasm. He said it could be done quicker to fit in another surgery, but he feels it's best to not stress and only have this procedure today. I was the closing person in the circle, and they all looked at me. The ODP then explained that I also have to introduce myself as I will be present. This was the first time I had spoken since all the team had arrived. I was told I could leave at any point, but I knew I wasn't going to miss a second of this procedure. Anyone who should be present but wasn't there at that moment was noted and given a brief of the meeting when they arrived by the ODP. After this, everyone starts scrubbing in. This means that they go through an elaborate ritual to completely sterilise your hands and arms, suiting up in sterile scrub with gown and gloves. This is essential for every person who will be in direct contact with the operating table. The ODP is the person whose main job is organising the surgical instruments and passing them to the surgeon when required. The ODPs are also responsible for ensuring sterile conditions and will help you put on the gown and gloves so that you don't contaminate anything. The operating room is a very strict and tightly regulated environment for understandable reasons. Maintaining a sterile field on the operating table is the paramount rule. I was explained by the ODP that as a student, your only job is to be sterile. Keep hands in front of you, above your belly button and below face at all times. Never adjust your itchy face mask and foggy eye protection with your hands. In fact, don't touch anything unless you're told. After scrubbing in, the nurse and I went to collect the patient from the ward. The patient was ready and only had one request. She had highlighted the front of her hair and wanted the highlights to stay in. This was annotated on the notes. I was shocked. So much care is taken in making the patient feel comfortable, and even the smallest things, so that they don't shave off the highlighted area, was annotated so the surgeons could read it. When we brought the patient into the anaesthetic room just beside the theatre, the surgeon and the registrar came, said hello, and then left the room, whilst the nurse and I went to wear gloves and apron. We didn't put the masks on until we were in the theatre. The anaesthetists then started their job. Once the patient was anaesthetised, the patient was then catheterised. I was asked a few questions from the anaesthetics team, which I didn't know the answer to, but they explained how it's important to temporarily put the patient in a coma, as when we were asleep we still move, which made sense. The doors were then open and the patient was moved into the theatre. I observed the whole procedure and didn't leave until the patient was awakened. I couldn't wait for the patient to be taken to the ward because there was no bed ready and it was going to take another half an hour and it was already really late. So I asked if I could come in the morning when the surgeon meets the patient to follow up. The surgeon said that would be fine and gave me an approximate time. Following the patient all the way through had helped me enormously, understanding the whole pathway before the patients come for radiotherapy who've already had surgery. It was a real eye-opener. Regards to teamwork in the theatre, in medical TV shows, surgeons are commonly portrayed as stereotypical personality, arrogant, aggressive, dominant, not a hint of self-doubt. That stereotype is kind of real. I feel surgical specialties are the most demanding fields, with the most training required and the longest working hours. Typically, only the best medical students would become surgeons. So when a surgeon acts like they're all obnoxious, as that may be, their attitude is likely deserved based on their superior knowledge and achievements, which only makes it more annoying because they're always right. During this surgery, a few things happened. Firstly, the scrub nurse stepped out for 20 minutes during a slow part of the surgery to take a lunch break. A somewhat new scrub nurse introduced herself and came in as a substitute. Whether due to inexperience or nervousness, or maybe both, she confused a couple of the surgical instruments when the surgeon asked for them. When asked to fetch a device from the stockroom, she came back empty-handed. We had to put the surgery on hold for a few minutes, waiting for the device while she went back. In the operating room, our faces are entirely covered, so looking at the eyes is the only way to read facial expressions. The surgeon didn't say anything and seemed to be desperately trying to restrain himself, but a quick glance at his eyes was sufficient. He was seething with fury. After what seemed like an eternity, the original scrub nurse returned to tag out the substitute. The surgeon checked that the substitute had left the room before launching into a 10-minute outbreak, laser-focused on her incompetence. There was complete silence in the room. What could anyone say? I was thinking, poor nurse. But it was obvious she knew she had screwed up, and at least the surgeon was merciful enough to spare her presence from his outrage. I thought of my training experience as a radiotherapy student, and only thing came to my mind, which is fragile egos beware. I feel as a student the pressure is what molds me into trying to be an exceptional radiotherapist, but only when the pressure comes in small doses. Barring these 10 minutes, the communication and teamwork between 8 staff members was brilliant, which led to the completion of the surgery with no problems and completely successful. I wasn't expecting any form of teaching or even communication from the surgeons, especially when you consider that their job is to treat the patient with your education a far lower priority. Many placement sets have not had the time to teach me, so I was expecting the same. But the surgeon not only tested me by asking questions directly to me and not the medical student, but also allowed me to come up close to the operating table, and at one point was having a drilling session on anatomy questions, and I answered 8 questions right, whereas the medical student only answered 7. So I won, feeling proud of the anatomy taught on the radiotherapy degree. A few hours in the surgery, the surgeon could see that it was becoming difficult for 2 students to find a good place to stand to view the procedure, so he said, "You're the short one. Why doesn't the medical student stand behind you, so that way you can both see and you're not taking up different places?" The surgeon made a point of making sure that we could see at every moment and not blocking the view. Small things like this really made me think, if one is a good teacher, then it makes it so much easier for the student to learn from every experience. I have always believed that one has to be comfortable in order to be confident, to show competence. This surgeon and the remaining staff really helped make me feel comfortable, to some extent even more than what they did with the medical student. This was probably because he entered 2 hours after the surgery had started and they did not appreciate this. However, having said that, the registrar did not talk much to me initially, but he observed me closely every time I spoke. The registrar spent more time talking to the medical student, and I found him a little intimidating. However, in the final 2 hours of surgery, the registrar started asking me questions regards radiotherapy and if I could explain what it is that we do exactly, so the medical student could learn. So I nervously started explaining, knowing the registrar was paying attention to what I was saying. Having said that, the medical student and I were comfortable with each other after spending nearly a whole day, so he made me comfortable in explaining and answering his questions. The medical student had decided that in his week of elective he wanted to spend time in radiotherapy department. I felt to myself, mission accomplished. Surgeons not only have to learn all the surgical procedures, but they also have to know medicine. A patient rarely comes into the hospital with solely surgical issue. This surgeon had to take into consideration during management the optic chiasm, which made the whole procedure very intense and difficult. The registrar said at one point that because medicine is constantly evolving, surgeons need to dedicate their lives to studying and learning so the patient gets the best possible care. To which I responded, I feel any healthcare professional would have to continue studying. I said before starting this degree, I considered my lifestyle and knew that I wanted to continue learning, and oncology is a field that provides me with that lifelong learning, constantly improving my skills and giving my patients the opportunity for a better life by providing evidence-based treatments and information. I think saying this really helped because the registrar just smiled, which I could see from his eyes, and responded by saying, "Well answered." The registrar at the end, before leaving, said thank you and well done for not passing out and for staying through the whole procedure. At the end of the surgery, I asked the surgeon one question. How do you attain such expertise and make such a risky and dangerous procedure look effortlessly easy? The surgeon took his mask off, laughed and said, "As surgeons, we do not intentionally kill or harm patients, but patients can die or their lives can be affected as a consequence of the complication of surgery, and that might be related to the technical factors or errors of judgment or management by us. Equals with territory, it's part of our job. We do the best we can." I couldn't believe how honest he was and acknowledged that mistakes happen and surgeons can make a wrong judgment, but holding on to it will not help. These words from the surgeon changed my perspective as a student. I realized that a neuro-oncologist surgeon can make a mistake and accept that they can be wrong and move on. Then why do I, when I've made a mistake, there's no going back? But maybe it's not the staff that make me feel this way. Maybe it's me who makes myself feel this way. But from that day I decided I will not doubt my ability and competence because I made a mistake in answering a question. This was a learning curve and has helped me a lot in building my confidence in the radiotherapy department and not feel belittled. The surgeon, the registrar and the whole team thanked me just for being present. I think it goes a long way to show a bit of appreciation to the student who is feeling a bit out of place with people who have such high skills and know exactly what they're doing. So to just say thank you or just acknowledge them, it really goes a long way. And I felt from observing this craniotomy procedure that day is something that I will never forget, and I had an absolute brilliant experience.